MLT Case Study Series 24. A case study on the topic. Navigating the Bullseye, a clinical and laboratory approach to diagnosing Lyme disease. An insightful case study on the integration of symptomatic evaluation and serological testing in Lyme disease diagnosis. Overview. Definition: Lyme disease is a tick-borne illness caused by the bacteria Borrelia burgdorferi and, less commonly, Borrelia mayonnae. It is transmitted to humans through the bite of infected black-legged ticks, commonly known as deer ticks. Epidemiology, predominantly found in the northeastern, mid-Atlantic, and north-central regions of the United States, but also present in Europe and Asia. Transmission. Transmitted through the bite of an infected tick. Ticks must be attached for at least 36 to 48 hours to transmit the bacteria. Symptoms. Early stage: fever, chills, headache, fatigue, muscle and joint aches, and swollen lymph nodes. Erythema migrans (EM) rash occurs in approximately 70 to 80% of infected persons. Late stage: severe headaches, arthritis, with severe joint pain and swelling, facial palsy, and heart palpitations among others. Diagnostic methods. Serological testing, the most common method, involves testing for antibodies to B. burgdorferi. Initial testing with an enzyme immunoassay, EIA, or immunofluorescence assay, IFA, followed by Western blot testing for confirmation. Direct detection methods include polymerase chain reaction, PCR, for DNA of B. burgdorferi, culture of the bacterium from a clinical specimen, and detection of the organism by immunofluorescence or electron microscopy. These methods are more commonly used for research rather than routine diagnosis. Interpretation of results. Positive serology indicates exposure to B. burgdorferi but does not necessarily confirm active disease. Clinical judgment is crucial, especially in endemic areas where a significant portion of the population may test positive for Lyme antibodies due to past exposure. False positives can occur, particularly in individuals with other bacterial infections, autoimmune diseases, or previous vaccinations for Lyme disease. Sample case study: Patient X. Background. Patient X, a 35-year-old male, presents with fever, headache, fatigue, and a large, expanding skin rash that resembles a bullseye on his thigh. He reports a camping trip in a Lyme disease endemic area 2 weeks prior. Laboratory findings. EIA for Lyme disease, positive. Western blot for Lyme disease, positive for IgM and IgG antibodies against B. burgdorferi. Additional tests: no signs of other tick-borne diseases or autoimmune disorders that could cause a false positive result. Discussion. Given the clinical presentation and the positive serological tests, Patient X is diagnosed with early localized Lyme disease. The presence of the EM rash, a hallmark of Lyme disease, along with the history of exposure in an endemic area, supports this diagnosis. Interpretation of serological tests. The positive EIA indicates exposure to B. burgdorferi. Confirmation by Western blot, which is positive for both IgM and IgG antibodies, suggests recent infection given the IgM positivity. In the context of the patient's symptoms and exposure history, these results are diagnostic for Lyme disease. Clinical decision. Based on the CDC guidelines, the diagnosis of Lyme disease can be made based on the clinical signs, notably the EM rash, and a history of possible exposure to infected ticks, supported by laboratory testing. Treatment should not be delayed pending serological confirmation if the clinical picture is strongly indicative of Lyme disease. Treatment and follow-up. The recommended treatment is oral doxycycline for 10 to 21 days. Patient X should be informed about the possibility of post-treatment Lyme disease syndrome if symptoms persist and advised on tick bite prevention strategies. Conclusion. This case study illustrates the importance of integrating clinical findings with laboratory results to diagnose and treat Lyme disease effectively. Medical lab technologists play a crucial role in this process, performing and interpreting the tests that guide clinical decision-making.